Memory Assessment Services Restoration and Recovery webinar. Delighted to have you all here. You've taken the time out from very busy days, and this is the middle of a clinical day. My name is Bikram Raychaudhuri. I'm one of the GPs. I'm also one of the clinical leads in the KSS region for dementia. And we hope that this will be one of a series of webinars to discuss dementia and memory services and where we go forward in the future. Could we go on to the next slide, please, Rachel? Rachel, thank you. So just at the beginning of the webinar, just to make the presentation and webinar as slick as possible, we were hoping everybody could turn off their videos and their mics so that reduces the bandwidth issues, and hopefully then we'll be able to have a much better experience. And the only thing we'll share is the slides per se. One thing to be very careful about, and you'll see that on point number 1, is that if people are calling in, then clearly you may have challenges with seeing the chat box. Also, if you come in as a guest, so you're not accepted the invite, then you may struggle to hear to see the chat box. And we'd really recommend using the chat box for all questions and conversations rather than doing it by the microphone. And we hope that that will allow us to keep a tag of all the questions that are being asked, which we will include in the FAQs that are done at the end of this presentation. If possible, especially if you're logging in as a guest, if you could put down your the organization you represent, that would be very useful. But we will try to make sure that all the webinar is being recorded, and the recording will be available through the NHS Futures platform. Next slide, please, Rachel. Thank you. So as I said at the beginning, the aims of the webinar is to look across the Southeast, which is Kent, Surrey, Sussex, Hampshire, Thames Valley, on how we are dealing with problems which we are all facing currently. So pre-COVID, we all had different structures. Post-COVID, we are facing the same problems. As we've probably realized, it was very easy to shut services down, but it's very difficult to start them back up again. So the aim of this webinar is hopefully to give you a representation of what different services, all of which are quite different from each other actually, may be doing or have done during the pandemic and in this recovery phase. What are the ideas going forwards, and which of these are things that you could possibly use in your own services? Some of these will be relevant for you, some may not be, but that's also part of the learning of how we go forward from here. If we can arrive at a consensus, that'd be great. For questions and answers, we'll try to do 15-minute presentations and 5 minutes Q&A after each presentation, but clearly that will need to run to time, and I will try to make sure that we stick to time. I know it's just an hour and we're all rather busy people. Next slide, please. Thanks. So as we've said, I am Dr. Bikram Raychaudhuri. I'm a GP in West Sussex. I'm also the clinical lead for dementia in the coastal Kent and Surrey and Sussex region. I am joined with a very esteemed group of people who will hopefully give us ideas of where we go forwards from the future. I'm not sure if Dr. Sian Roberts is here yet. Dr. Roberts, are you here?
Yes, I am. Sorry. Yep.
No,
Hi.
Are you able to introduce yourself?
Yeah, I'm Sian Roberts. I'm a GP and I'm a clinical lead for dementia in Hampshire and Thames Valley region for the SCN.
Chris, are you able to introduce yourself?
Yes, hi, Chris Kipps, clinical lead for dementia in Hampshire and Thames Valley as well, along with Sian.
Thanks, Chris. Joe?
Hi, I'm Jo Gavins. I'm quality improvement lead across Kent, Surrey and Sussex.
Rachel?
And I'm Rachel Chappell. I'm the quality improvement lead across Hampshire and Thames Valley.
Thank you. Raja? Raja? Okay.
Oh, sorry, I was on mute. I'm Raja, I'm an old age psychiatrist, and I'm Associate Medical Director for Older Adults at Surrey and Borders.
Thanks, Raja. Just a reminder for everybody who's logging in new, if you could keep your mic and your video off, that might help us with bandwidth issues and hopefully make the presentation slicker and more memorable. Jason.
Hi everyone, I'm Jason Wilcox and I manage the Brighton and Hove Memory Assessment Service.
Thank you. And finally, Phil.
Good afternoon, everybody. My name's Phil. I'm a dementia nurse specialist and I work in Buckinghamshire across memory clinic services there.
Thank you very much. Next slide, please, Rachel. Thanks. Just one other, I suppose, a warning, I suppose. If we do have any IT glitches on this webinar, we'll try not to, but if that arises, please bear with us and we'll try to sort out what we can. And now moving on to Raja. Raja, are you with us?
I am. Can you hear me?
Yeah, we can hear you. Are you able to take it on?
Yeah. Hi. Next slide, please, Rachel. So what I'm going to do is to try and go through with you what we are doing in Surrey and Borders in terms of managing our memory service across community and in care homes, and also try and discuss with you pilot that we carried out to understand what works well and what doesn't work well in terms of virtual platforms. Next slide, please, Rachel. So that's what I've said. Next slide, please. So this is our data in terms of number of contacts that we've had in terms of memory assessments and also other types of assessments. So as you can see, since March post-COVID, we've had about 1,200 odd face-to-face contacts and 5,560 virtual contacts. And virtual includes phone and using electronic interface such as Attend Anywhere. So it's fair to say that 4/5 of our contacts during this time has been electronic and telephone based, which I'm sure is what you would have experienced as well. Just to say, we haven't completely ruled out having any face-to-face contacts. Our policy has been very simple: do the screening questions for COVID, get consent for face-to-face, and make sure that there is standard PPE for staff to wear. So as long as those three criteria are met, then we have carried out face-to-face contacts even during this period. Next slide, please. Okay, so we're going to focus on the community, and I'm going to talk to you about the remote memory assessments guidance that our colleagues here, psychiatrists and psychologists, have built to help us during the COVID phase and also during the recovery phase. Next slide, please. So this is not by any means self-promotion, but I did devise a very simple screening tool for GPs to use, for acute hospital clinicians to use. It's based on the word forget. Symptoms should be present for at least 6 months, and if carer or the patient, if possible, could be asked those questions: are they forgetful? Do they fail to recognize family or friends? Do they have any odd beliefs or out of character behavior, repetitive or reduced speech, grooming problems, evening confusion, toilet awareness? And if you score 1 for each of those, more than 1 is very significant in the community and will need further cognitive assessment. So that's a very useful tool, I think, for our primary care colleagues to use even by the phone. Next slide, please. One thing that we have realized that it's extremely important to be aware of the cultural, language, and emotional and social background that the individual that we're assessing comes from, because communication over phone or by any electronic interface is not very similar to doing a face-to-face assessment, and we need to be very careful about that. Another important thing to make sure is about screening for sensory impairment of any kind. And it's always good to see if it will be possible to have a family member or carer being present either virtually or with the person who are assessing. So these are some important checks that we carry out during this very difficult time. Next slide, please. What we have subscribed to as first line assessment is telephone interview for cognitive status, called as TICS. We have purchased that, so it's copyright protected, so we had to purchase it. And it's a very elaborate purchasing process, and you need a psychologist who's registered with the Psychological Society to be able to do that. It's a very useful tool. It's a very reliable tool. That was the first ever study that was published way back in 1991. I'm sure things have moved beyond that. Next slide, please. There are two versions of it. There's TICS, the standard one, and TICS, the modified one. They're both reliable and validated. Next slide, please. As you see, there's cutoff scores for MCI and for dementia. The advantage is that, and as we have found out, it's very easy to lose internet connection, either as a clinician yourself or as patient or family member. So what we advise is to use TICS even as a tool for assessment through electronic interface, because if Attend Anywhere goes down, then you can easily convert it into a telephone conversation and you'll still be using the same reliable tool. So that is the first line of cognitive assessment, and it's been quite successful in some of the consultations that we've had. We have been using it in terms of, from the slide that I've showed it to you, but the actual tool itself, we've just bought it and it's being sent to us. Next slide, please. You would be aware of Merker Blind. Again, that is a reliable and validated tool, and dementia clinical networks do advocate using Merker Blind using electronic interface. So that is another option in terms of doing cognitive assessment that we've been carrying on for the last few months. Next slide, please. And that's a study to say that Merker Blind has been evaluated. Next slide, please. And then there is ACE, ACE3, a lot of you would be familiar with, at least in secondary care. ACE is a very good diagnostic tool because it's also validated for some of the subtypes of dementia, and it's proved its credence several times against neuroimaging as well. So it is a very, very useful tool. It comes with its own inherent difficulties in terms of converting it into a tool to be used on an electronic interface. If you want to know more about how it could be done, then the link on the presentation will take you to the website run by Professor Hodges, who was involved in development of the tool, and it is very simple and easy to navigate to find out how it could be done. The only thing that I would say to you is that what I have found that to be useful is to make sure that there is someone present with the person who you're trying to assess. And what I've also found is that it's useful to post the actual ACE questionnaire by post. So they do have a hard copy in front of them when it's being done through an electronic interface. So those would be top two tips that I will give you to make it a very successful consultation. Next slide, please. So once people have had their cognitive assessment, we are also open to carrying out neuropsychological assessment, and these are being carried out by our psychology colleagues. And we came up with this criteria, which is based on using TICS as the first line assessment. It is also based on ensuring that the neuropsychological assessment is carried out for ruling in, ruling out MCI, coming to terms with uncertainties, especially with regards to subtypes of dementia, and where there is someone who's under 65 who's presenting to memory services. So those would be the kind of major criteria for going beyond standard cognitive assessment to explore the possibilities of diagnosis of dementia as well as subtypes of dementia. Next slide, please. So once we've diagnosed and where people are eligible for cognitive enhancers, so acetylcholinesterase stress inhibitors or memantine, then a lot of people do have electronic devices to check their pulse. So that is a very good thing to ask. If you're prescribing care homes, then it becomes much easier because care homes do measure pulse regularly. Renal function tests are generally available even at the point of someone being referred to memory service as such, so we haven't had any problems with prescribing memantine, ensuring that renal function is okay. We have developed links with pharmacies so we can scan and email them prescriptions. At the moment, we are piloting e-prescribing in the community, and that is going very well. And all our medics and nurse prescribers will be able to do that starting from August, as we've all been booked to undergo e-prescribing training. So that will become the main portal for prescription in future. And I think it saves a lot of hassle in terms of ensuring that prescriptions are appropriate, delivered, and people do get the appropriate medication. So we have continued with prescribing even during this difficult time. Next slide, please. At the moment, post-diagnostic support is a bit difficult because of limited face-to-face consultations, but the general feedback is that telephone consultations, telephone diagnostic support is going fairly okay with patients and family members. We have used Teams and Attend Anywhere for having these meetings. The only thing that I would say about having Teams is that as it stands, it does mean that there will be a permanent trace of contact, and people can always send messages on Teams, even though Teams, although even after the Teams consultation has ended. So we're trying to make sure that when we send out letters to say that this is a one-off thing, and if you want any further advice or if there is an emergency, then you should go through regular route rather than leaving message on Teams. So that's something to be careful about. Whereas in Attend Anyway, it's a one-off link and you wouldn't have that problem. Next slide, please. Just to go back to that, we managed to carry out a successful group session for young onset dementia people just as of last week electronically using an electronic interface, and it was very well received by the patients and family members who attended it. So I think there's a big scope for improving on that in future. So we carried out a pilot of Attend Anywhere and other remote assessments to see what patients felt and how successful they were. So I'm just going to give you some data on that. Next slide, please. So we looked at 70 consultations. Most people agreed for the virtual consultations, so roughly about 2/3. And of those who agreed, most of them agreed to using Attend Anywhere. Next slide, please. So 2/3 of those consultations were successful, and they did not need any further face-to-face consultation to be completed. Remote memory assessments, including ACE3 and MOCA, were used in 1/3 of the patients. One of the biggest hassles that happened whilst we were trying to carry out the pilot was Attend Anywhere went down. And then those consultations had to be turned into telephone consultations, and which is where we realized the lesson that actually having a tool that's validated over the phone would be a good place to start, and hence why we are using TICs to do cognitive assessment. Next slide, please. So the conclusions are that things work well as long as the electronic interface works very well. It is possible to carry out very reliable, structured cognitive assessments using an electronic interface. And as I said, it's important to start with something that could be carried out over the telephone in case the electronic interface fails. And they do significantly reduce the need for face-to-face consultations for our more vulnerable elderly patients as such. Next slide, please. So I'm going to briefly talk about care homes and how things have changed in our care home work, especially with memory assessments. Next slide, please. So one of the most important things is to try and make sure that enough background information could be collected from family members, from care home staff before the actual assessment itself happens. And we always offer remote consultation as the first line, and then we take it from there. But the emphasis is always on gathering adequate information preceding the actual appointment in itself. Next slide, please. So once we do offer the appointment and we do carry out the assessment as normal, one of the important things to understand is that whilst we have been successful in observing behavior, especially challenging behavior using the electronic interface, it is a very delicate issue when you're trying to deal with behavior challenges that happen in the context of providing personal care. And certainly we have run into problems using that. So you have to be very careful. And as a standard measure at the moment, we are not using electronic interface for observing personal care related behavioral problems as such. Next slide, please. One thing that we've learned from this exercise is to make sure that there is adequate documentation of capacity in terms of consenting to using an electronic interface as an assessment tool, and where someone lacks capacity, to not just involve the care home, but also to involve the family to get their opinion in terms of forming a best interest decision along proceeding with using electronic interface for assessing, including challenging behavior. And it's also important to ensure that things are being deleted where they're being recorded. We don't start by recording it. It's usually a electronic interface rather than videos being sent around. Next slide, please. We also developed care home pathway support, and there are the links for care home staff to understand about a lot of things, including understanding about behavior, de-escalation, supporting people when they're being isolated, and they've been developed by Katie Lee, who's our psychologist who leads the care home pathway, and they are on YouTube, and it's available for anyone to use, and it's received a lot of positive feedback, and I would encourage people to utilize it. Next slide, please. So, in summary, electronic and telephone interface do work. It's important to ensure that people consent to it, and where people can't consent, there is a wider discussion about coming to that decision using the best interest principle. Please do start with something that can be changed from one interface to another, so something that could be reliably carried out using telephone or by other electronic interface. A lot of elderly patients do have access to electronic means, and including measuring their own pulse rate, so it's important to utilize on those things that exist. And where challenging behavior is present, it's important to understand the importance of ensuring that they consent, especially where it involves very difficult assessments of complex behaviors. So I'm going to leave it at that, and I'm happy to take any questions.
Thanks, Raja. That was very interesting. And I note on your point of the importance of pre-consultation information gathering, Chris Kipps has also included a link to the Wessex Dementia Toolkit on the chat box. So that's another tool available, just highlighting the fact that it's all about the information. It's all about the history. I mean, so many things have changed between what's pre and post COVID, isn't it? I mean, so many things I could ask you about. But one thing I did want to ask while I'm waiting for any questions to pop up in the chat box, you mentioned tics, you mentioned MoCA blind, ACE3. How do you choose which one to use in any particular consultation? I know you mentioned the telephone is tics clearly, but how do you choose the others?
So, so going forwards, our first line is going to be tics, simply because if we start with an electronic interface and if it fails for any particular reason, then tics is validated over the telephone as well. So it becomes easier to convert the consultation into a telephone consultation as well. So in that sense, tics is very useful. But where there is complexity in terms of trying to arrive at the subtype diagnosis of dementia, and where further cognitive testing would be helpful, then it's useful to then build on it and use something like Addenbroke's cognitive examination.
Okay, thank you very much. I can see a question over here saying, with face-to-face assessments, do you prefer home visits or do you have running hospital clinics? How are you choosing that?
So at the moment, most of our home visits, most of the face-to-face consultations have been home visits. I would say 90 to 95%. The problem with getting people into clinic is that we operate a hub system mainly, and the hubs are being shared by other services as well. And the reception area is common to everyone. The car park area is common. So it becomes very difficult to restrict in terms of exposure as such. We have a plan in place to get clinics running on a regular basis from the hubs, but the focus and emphasis is still on ensuring that where things could be carried out virtually with a strong reliability built into the system, then that will be our first line. where there are risky issues or where there are immediate concerns which need face-to-face, then we will carry out face-to-face as first line, but that will be mainly home visits.
Okay, and just in the interest of time, I'll keep it to one other question. I can see over here there's a suggestion, the Forget screening tool. Was that a pre-COVID or post-COVID develelment? Was that?
It was something that I developed and validated and published in 2014. So we've used it quite a lot in liaison services in the past and in the community where I was working.
Thank you very much, Raja, and lovely, excellent presentation. Enjoyed that thoroughly. Shall we move on to Jason now, please?
Thanks, everyone.
Yeah, hopefully everyone can see me. So I'm Jason. I manage the Brighton Hove Memory Assessment Service. And before we dive into what we did for COVID, I'll take you through a little bit about our service and how we're structured. So if you go on to the next slide, please. So our model, we're an integrated community service and we provide clinical and support functions to people who are 60 years and over. We operate out of primary care locations and we also deliver home visits. Our support pathway is a little bit different to most. It was a post-diagnostic support service and then we redesigned it in 2016 to put support at the point of referral. So we support everyone through their journey with us. We are a nurse-led service, so the nurses deliver the assessment, the diagnosis, the medication review appointments, both titrating and annual. And we have a weekly MDT, which has consultant input. Our doctors are there as well. And sometimes we are lucky enough to get our support workers there as well. So that's where the diagnosis happens. And then we also have access to MRI and CT scans. So if we go on to the next slide, I'm just going to draw your attention to our staffing structure. So we're a pretty small team, and you can see in the top right-hand corner, it's whole-time equivalents there, and then just some other key indicators if people are interested in the service and how it performs. I generally describe it as we're a very lean service, and we punch above our weight in terms of the output of assessments in what we deliver. So if we go into the next slide. So before I talk about COVID and what we did, I think it's really important to look at our service purpose. So in 2016, we redesigned our service out of a systems thinking approach that was based on patient and staff engagement. And we listened to what people wanted, and we found that 70% of people that we spoke to or observed their appointments or went through their case notes was actually looking for support and as their priority, and it wasn't diagnosis. So once we knew that, that's why we put our support at the front of the service. And we really feel that this has shaped everything we've done really since 2016 and was particularly important in shaping what we did in terms of our COVID response. Next slide, please. So the impact to our service was similar maybe to most, not to Raja's, but for us, face-to-face stopped, scanning stopped unless it was urgent. The medication titration was paused, and we released 50% of our doctor capacity, which is 2 of our doctors, so just leaving 1, to the COVID response. And what was the impact to our patients? Well, apart from them being vulnerable to the infection and the effects of it, what was the impact to their networks? And we really felt that being a support service, we were aware of the destabilization that there might be, the isolation, the risk that this would mean that people would turn up in crisis points. And we really wanted to stay open if we could. And we felt that if we could work proactively and if we could shift some of our function, then actually we not only just helpful to the quality of life, safeguarding for our patients, but actually what could we do for the wider system? So if we go to the next slide. So how did we stay open? Well, I think it's helpful that the MAS service is an actual commission service in itself. It's not bundled into any other service. It's a standalone one. We're a social enterprise not-for-profit, and the staff that were seconded into us from SPFT, the trust, they actually had underlying health conditions that meant that they wouldn't be the first choice to be released to a COVID response. And we wanted to be helpful to the wider system. So I've included some guidance and some guiding values that really helped us shape our decision making and really unpick some things as we went through the service. You know, that and our service purpose really has shaped what we've delivered. If we go to the next slide. So the first thing we did in terms of our BCP response was to look at our critical functions. And you can see up there that we've got medication management, risk management and support. And we actually downgraded our assessment and diagnosis function, which seems counterintuitive because we've all been chasing that and that's our function. But given that we're an integrated service, support was key. And really quickly in terms of our delivery model, we switched to a telephone consultation model really quickly, essentially overnight. We had all our staff in the support and clinical pathway had VPNs, laptops, mobile phones because they delivered home visit appointments, and we got that tech quite a few years ago. So it was really easy for us to maintain the function and just work remotely. The telephone assessments we delivered really focused on gathering the history, the presentation of symptoms. We worked hard to get as much collateral history as possible. We re-requested any scans that we could see on the system, and in our service, these scans are reported by neuroradiologists. But in terms of the challenges to delivering via telephone, we didn't find it too hard actually. In 2018, we redesigned our assessment templates to be very prescriptive, and they were based out of the ICD-10 criteria. And it really walked a clinician through the domains and the questions that we really wanted to ask to ensure that when, you know, there's a really rich history. So when people do come to the MDT to have their diagnosis made, we've got all the information we need, and we're assured that the questions have been asked, or, you know, if they haven't, that they're marked as that didn't apply to the patient. Scanning for us, well, we haven't stopped scanning now, but it was available to us if there was an urgent need. And what that's meant was that most of the people that came through for diagnosis through the service during the pandemic is that we have been looking to try and make a diagnosis without the scan. And for us, scanning is really part of a routine process, although we're mindful not to overscan people. And we are aware of the conversations in the wider community about, you know, how long it takes to get a scan, the value of it, and the impact that it would, or the benefit, if you like, that it makes to the diagnosis. But it has been quite difficult for our doctors to release that because they do like to have that bit, really just to exclude things for their own sake, that they said, because they're always telling me, you know, it's 80% is in the history, and I've seen that being in the MDTs. So if we just go on to the next slide, this just shows us that we've maintained some of the activity, but at a lower level of diagnoses made during the pandemic. If we just go to the next one. So in terms of the priority that we had in terms of our service, we really focused on support, and this was across the clinical and support pathway. We wanted to create a risk stratification tool that would really help us understand the need and also understand the potential risks in the support network. So we created a tool that lends itself to the carers risk stratification tool that the local authority use and the Alzheimer's Society's welfare calls. So when we would be talking about patients, sharing information, we were trying to use the same language. And during these reviews, and you can see how many we've completed there, we've really asked, you know, who are people supported by? Do they have friends, family, neighbours that they can go to? Do they have access to their medications, their food? And do they have access, importantly, to technology? And we really wanted to make sure if they did have access, could they use it, because we were mindful that internet would be a great source for people if they could use it, and also mindful that we wanted to move to remote delivery, so video consultations, things like that. At the end of each review, each patient would get a grading, and that low, medium, or high risk, and that allowed us then to focus our resources on the people that we were most concerned about, and then deliver welfare calls or enhanced welfare calls. And these welfare calls really focused on exploring the support network, exploring what people needed, were they able to get food, medication, were they fine financially? And the idea was to connect it with all these new COVID community response services that were popping up across the city. For people where there was risk and needed urgent input, they were referred on to enhanced duty, so a 4-hour response. And for very vulnerable and isolated people, we also registered them on the government's website. And as we did all of this, we created COVID support letters, which when I pulled the report, was logged at 666 being the number we've sent. But I know that we sent a few hundred out before that point. It's just reporting functionality was introduced later. And in terms of that, really the vulnerability and isolation review template is something that's now embedded in our clinical tree in System 1, and it's reviewed in the same way that we review risk at every appointment, just so we can plan for the future. If we go on to the next slide. So this graph just shows the support functions that we've been able to maintain. So in the early days, you can see business as normal functionality, and then as we've introduced our COVID specific appointments, we've delivered them side by side in terms of BAU. And if we go to the next slide, that should also show you the same for the clinical team and the type of activity and the number of things we've delivered. And the next slide. So where are we now? Well, with lockdown easing and people being able to go to pubs and restaurants, we have had the conversations with doctors returning only in the last, or since mid-June really, whether we should go back to face-to-face or remote. And we felt that our patients are still vulnerable, the risk is still out there. We also work with primary care, so we deliver out of primary care services, and they're only starting to get to a point where they are working out how they might work with community services and how we'll manage the waiting rooms when they don't know who's turning up. So we've stuck with remote for the time being, and we feel that that will ensure that hopefully, whatever the future brings us, second, third waves, winter flu season, that we will have a resilient offer that we can continue to keep our service operational. We're looking at remote prescribing, so we've been initiating people on memantine during the pandemic, but now we're looking at donepezil and rivastigmine now that our doctors returned. So, how do we get the pulse check? Well, we're looking to lean into district nurses who go out to deliver. As Raja said, many patients have stat machines, BP machines at home that can give a pulse reading to us, and we've also put a request into the COVID tech cell to request stat machines for all our patients in our medication pathway. We are very mindful that we don't want to exclude people by using tech, so hopefully from mid-August we'll be starting to deliver some medication initiation appointments, and then from September onwards we'll have face-to-face delivery, but at a lower activity level. For our cognitive assessments, we're looking at the ACE3 to deliver, and hopefully next week, fingers crossed, our nurses will start to pilot that. And that coincides quite nicely with the easing of lockdown, because user failure is really the issue that we found in terms of not delivering remote testing earlier or video consultations. User failure in our team, people didn't feel that they were comfortable using it, but also for our patients, they rely on their next of kin, their family members, to support them. So we're hopeful that the uptake will be quite positive. We've had lots of people booked in already. So fingers crossed. And we've chosen the ACE because it's the tool that we're most familiar with delivering. It's the tool that we're most familiar with analysing. And it felt like if we were to move to a tool that we don't use very often, that's not very helpful in terms of the quality of delivery and analysis, and also the experience for our patients. And the next slide. So really in terms of the tech, it's and the relaxing of IG, it's been very helpful. So we've now got access to electronic prescribing, which we've wanted for quite a few years, but we never quite got there. So that's going live tomorrow. And I think in terms of the tech solutions that have been brought in, it's going to mean that we've got a more diverse offer to people to really help fit the needs. And I'm not sure, how successful it will be for us, but I think that it will be part of the offer that we have, and that it's going to be more diverse and hopefully an even more patient-centered service. And I think that's the end of my slides, or at least I hope so. It is great.
Thanks, Jason. That's a great presentation. I mean, you clearly kept the focus on the patient's needs, which is good to see in a service as always. A theme that's emerging from the chat box was, given the rapidity of transformations that have happened, do you have any view on how you'd assess the quality of the transformation, pre, post? Have you had to make compromises, and how far do you see this continuing forwards?
I think in terms of how agile and the transformation that we've delivered, we're quite lucky that we're a small team. It's much easier to deliver transformation and get everyone, 6 people on the call and have that's your clinical pathway. We've still maintained our governance meetings, our quality sessions. We've created an SOP that's COVID specific and ensured that it captures all our changes. So I was really mindful that, there's a huge amount of change very quickly, and actually for clinicians, for support workers, it can be very daunting for that and to work in a new way. And we wanted something to really evidence, to acknowledge that people are making decisions in a different environment. And we've managed to capture that through our System 1. And the quality, I think we'll have to see from the patient's experience in time on that. But from the feedback that we get is that the assessment that we've been delivering is good. It's a good experience, but also there's nothing like a face-to-face personal touch for people.
Thanks, Jason. Yeah, I agree. What we're doing now is a change, and we have to see how effective and valuable it is. Let's see how it goes for the future. It depends on all the other circumstances surrounding. And just as a comment, I'm aware that in West Sussex and Horsham, there is a trial going on how patients perceive remote assessment. So we'll see how that reports. Just in the interest of time, I'm going to move on to the next presenter. So thank you very much, Jason. Phil, are you there with us?
I am. Can you hear me?
Thank you, Phil. If you could take it on from here, please.
Fantastic. Good afternoon, everybody. My name is Phil. I'm a dementia nurse specialist, and I work across memory clinic services in Buckinghamshire. Rachel, can we have the next slide, please? And another one. Fantastic, lovely. So back in the 3rd week of March, things changed dramatically in our service, as I'm sure it did in every service across England. And overnight, we stopped meeting with people on a face-to-face basis. We did continue with telephone reviews. These were for people already under our care, already on memory enhancing medication. Those reviews were maintained by telephone, but we terminated all of the face-to-face review, all the face-to-face appointments, and consequently, we were seeing nobody for new assessments. What we quickly realised was that not only was the waiting list growing, but also we had people ringing us up who were happy to wait for a memory clinic assessment for 3 or 4 weeks, but they couldn't tolerate the idea of waiting indefinitely. And we had the option of referring people to the community mental health team where there were acute crisis situations. But I think for many people, they weren't in acute crisis, but there was a sense that they wanted an assessment. They were looking for support, advice, signposting, and in some cases, a diagnosis. and GPs were calling us up and saying, look, this person would benefit from a diagnosis if appropriate, because that does open doors to other services. Maybe that shouldn't be the case, but it often seems to be so. So next slide, please, Rachel. So I'll tell you a bit about how we normally work, and then I'll explain how we adapted our response during COVID. We normally operate something called the MACH one-stop shop, MACH, memory assessment closer to home. So we operate clinics from our main bases in Aylesbury and High Wycombe, but also we have clinics based in GP surgeries. Up at the top of the county, we have a clinic in a surgery in Buckingham. Down in the deep south, we have a clinic in Denham. And then over towards Oxfordshire, we have a clinic at a surgery in a village called Haddenham. And what happens normally, people come in, the patient comes in with somebody who knows them well. It could be a carer, a relative, a friend or a neighbour. And there are two clinicians as well in that assessment. The assessment's led by either a consultant psychiatrist or myself. And after some preliminary introductions and some questions, my colleague will normally take the patient to do some psychometric tests, often a mocker, sometimes the ACE3. And whilst they're doing that, the consultant or myself, we would interview the relative or carer and get all of that background information. The assessment concludes with all four of us back in the room, and we will, where appropriate, establish a diagnosis, start treatment, and also talk about signposting, driving, power of attorney, and those sorts of things. It all happens in one assessment, and for most people, the day of the first assessment, they will go away with a diagnosis and some follow-up support as well. So very quickly in March, we were trying to think how we might maintain these assessments. We'd already realised that we couldn't maintain face-to-face appointments, and so we came up with the idea of virtual assessments, video assessments. And initially this was an impromptu pilot study, just myself, and I saw about 15 or 20 people for initial video assessment. And what I tried to do, I tried to replicate that one-stop shop model. So basically I would meet with the patient and their relative or carer over video link, and I would attempt in an hour and a half to administer the mocker, to get all the background information, the collateral information, and where appropriate, establish a diagnosis and start treatment. And at that point, I was using the mocker blind, which is, as Raja says, is validated and reliable. And most of you will know it's pretty much the mocker without the first bit. There's no construction tasks and no visual naming tasks. Next slide, please, Rachel. It worked pretty well. It was a learning curve. It wasn't a particularly steep one. I think after 15 or 20 assessments, I felt it had gone well. And the feedback coming from patients and relatives was pretty positive too. The one area I came unstuck was obtaining that third-party information. You know, the sort of thing where you say to the patient, how are you at cooking? And they say, fantastic, I'm a whiz in the kitchen. And then the relative chips in and says, well, actually, Mum, you haven't cooked anything for a year, and we turned the gas off after the last explosion. Those were the sort of conversations that came up a couple of times. And of course, at that point, the patient feels undermined and betrayed, and the thing begins to unravel. And then I spend the next few minutes trying to bring some harmony back to the interview, and everyone settles down again. And then I say, so what about shopping? And everything unravels again. So I quickly realised that getting that third-party information in the same assessment was dangerous. It could cause some difficult dynamics. So we moved to a different model. And next slide, please, Rachel. So all of the psychiatrists in Buckinghamshire, I think there are 9 of them, they've all undertaken video assessments now, but we're doing things slightly differently. One of our clinical colleagues, a social worker, occupational therapist, or assistant psychologist or nurse, they will make an initial telephone call to the patient to discuss the possibility of a video assessment, to look at issues of consent, and also to establish whether the patient will give us permission to talk to somebody separately who knows them well. Assuming we get that permission, there's a second telephone call, not necessarily the same day, to the third party, the relative, the carer, the neighbour or friends. And during that telephone call, one of my colleagues will spend about half an hour getting all of the collateral information that's going to be useful to us in order to get a robust conclusion. Now, in some cases, it may be that the relative is a husband or wife. They could be sitting next to the patient on the sofa, but it does give them an opportunity for a separate and discreet conversation where they can speak honestly about any concerns they have. And then the third and final part of this three-stop shop, that's the video assessment, and that's the consultant or myself connecting via video link with the patient and the relative. And in that final assessment, we'll bring all the information that we've gathered, add some further questions, administer the psychometric assessment, and then ultimately, if appropriate, establish a diagnosis and start treatment. Next slide, please, Rachel. We're using Microsoft Teams. It works pretty well. Our IT department recommends it for both security and stability. And we're mainly using the Mocha. In real life clinics, we'd use the ACE3 quite a bit, but we're using the Mocha because it is validated, and as Raja said, it's reliable. And we use the screen sharing function in Microsoft Teams. If you're not familiar with this, it's very useful. And if you think of the top of the Mocha, the first part of that test is the trail making test. And Mocha HQ, they tell us that it's perfectly acceptable to do this over video link. But the important thing is to ask the patient to indicate verbally where they would place the next line. And then we place that line. We use the highlighter function on a PDF document to add that in. And then the patient has a visual cue on their progress thus far, and then they indicate where the next line goes. That's consistent with the integrity of the test and the way that the Mocha developers have advised us to do it. In terms of copying the three-dimensional shape, very straightforward. We display that on the screen. The patient will need a piece of paper and something to write with, but they copy that from the screen. Clock face, simple, no visual prompt required. And then the naming tasks, again, the animals are just displayed on the screen and the patient is asked to identify them. At the end of that section, with the patient's permission, you can take a screenshot if they hold the piece of paper up to the camera. It takes a bit of synchronizing, but once it's up there, you can take a screenshot, save the images, upload them to the patient notes, and hey presto, you've got a complete Mocha. The one other thing I'd say about the Mocha, on the attention domain, where you've got the 29 letters and you ask the patient to tap normally where they hear the letter A, don't ask them to tap. You may not hear or see that. We normally ask for some verbal indication, just shouting yes every time I say the letter A, that sort of thing. It works pretty well. Next slide, please, Rachel. Penultimate slide, we're almost there. Challenges, the technology doesn't always work. You won't be surprised to hear this. Sometimes people have very old desktops and it turns out on the day the desktop doesn't have a camera or a microphone. Sometimes they're running old operating systems and MS Teams doesn't work on that. There are lots of other problems, sometimes unfathomable ones. But yes, the technology is inconsistent, but for the most part, we can work through it. Secondly, and this has already been mentioned, obtaining a pulse, pretty crucial stuff if you're thinking about a cholinesterase inhibitor. I have no simple solution to this. First of all, we always check the referral letter. Sometimes the medical record contains recent documentation of a pulse, and we have routinely asked GPs now if they're seeing their patients face to face, if they can obtain that information for us. In my experience, medical records often contain blood pressure results, but not pulses. But always worth checking. The patient may have had an ECG or have a pacemaker, in which case we're home and dry. A lot of people, and again, I think both Raja and Jason mentioned this, a lot of people do have home blood pressure machines, and on several occasions I've asked the person to simply take their pulse and blood pressure in front of me, show me the reading on the screen, and that works perfectly well. Most often and most successful, I've asked the patient or the relative to manually take the pulse. I have some misgivings about this. It is open to error, but it generally seems to have worked okay, and that's where I've been most successful. There are a number of smartphone apps which can take your pulse. They're very reliable, but it's one more thing for the relative to download or the patient, and something else that can go wrong. And then fifthly, we have looked at the possibility of obtaining pulse oximeters. Very easy to use. You drop them off at the patient's house the day before, they take their pulse, and then we could collect the machine with the data the following day. Works perfectly well, but realistically we just don't have the manpower. We have assistants, care assistants who can drop the equipment off, but it's quite time consuming acting as a courier service around the county, and generally we haven't really managed to implement that. Finally, a lot of people would consider memantine a safer alternative to the cholinesterase inhibitor if we can't obtain a pulse. Again, I have some misgivings about that. That's a separate conversation, but certainly memantine is to be considered. Thirdly, ongoing challenges. Can't do a physical examination over a video link. A lot of the time not essential, but generally I would like to check for Parkinsonian symptoms or frontal lobe symptoms. Difficult to do that over a video link. Fourthly, of course, this isn't particularly relevant to video assessments, but our access to neuroimaging and other investigations in Buckinghamshire has become more restricted. We don't routinely send everybody for a scan anyway in Bucks. We are quite selective, and so we probably only routinely send 10 or 15% of people for neuroimaging, but that number is even more restricted under COVID-19, and that does make assessment more complicated. Finally, in respect of challenges, video assessment is a less meaningful human interaction, and I can't deny that, and there's no way around it. Probably the most problematic aspect of the assessment is at the conclusion, if you are delivering bad news. Never an easy thing to do, but it's more complicated over a digital assessment. And even just gauging the response of people in the room, you can't always see people's facial expressions on a video connection. Your own body language is less apparent, and it is more difficult to maintain that human interaction. One more slide, I think, Rachel. Thank you. So this has all gone terribly well, but I have to say that statistically and percentage-wise, probably a fairly limited response to the offer of video assessments. I think we're getting sort of a 30% response rate, possibly less than that. And so we've just composed a letter to go to everybody on the waiting list. That will be dispatched next week. And there's two key messages in that letter. We think that a lot of people are simply waiting for normal service to resume. And as was said earlier, the pubs are reopening, the shops are reopening. A lot of people may consider that the memory clinic will be open as normal before long. It won't be. We will reinstate some face-to-face appointments, but there will be a limited number, and we will take a long time to get through the waiting list. If people are happy to have a video assessment, they will be seen much sooner. We want to stress that message. Secondly, connectivity is pretty straightforward. I had a gentleman last week who said, well, I can use Skype, but I don't know anything about MS Teams, so I'll wait for a face-to-face. To be honest, if you can use Skype, you can use Microsoft Teams, but I think people are nervous of the unfamiliar. You will all know you've connected today via an email and a link. You have to click on that link. That's all that's required. So we're stressing to people that connectivity is generally fairly straightforward. Finally, I'll just say that although we see video assessments as a core part of our provision going forward, we also are looking to reintroduce face-to-face assessments. There'll be a limited number because we need time to clean the rooms and we want to avoid creating waiting spaces. And at some point, we'll also reintroduce home visits. But our feeling is that video assessments are probably here to stay. That's the end of the slides.
Thanks, Phil. That was fantastic. I think a lot of themes are put up in 3 presentations. There's a thing about e-prescribing, which lots of people seem to be doing. The fact about technology, that there are positives to it, but also you need to be aware of what the negatives are. I think there's a comment here. Do you get somebody to do a run through before the actual consultation, running through the technological process, as it were, with the family?
We've just started doing that in the south of the county. We do a trial run in advance. On a few occasions, we've had technical problems and we spent the first 20 minutes just trying to iron those out. So, yeah, I think doing a trial run makes sense, and we've just started doing that. Yeah.
Okay. So thanks, whoever put the suggestion in there. That's a great suggestion. The other thing I want to ask you was the three-stop shop. I mean, it sounds like a great model. What's the time period it takes? How long does it take to actually do that? If you mentioned 1.5 hours pre-COVID, how does that correlate now?
So the first conversation with the patient themselves, that normally takes about 10 minutes as we're looking at issues of consent and permission to talk to a third party. The second telephone conversation, that's with the relative or the carer, that's normally about 30 minutes. We've been using something called the IQ code to gather information. We may change that, but it's a good template to sort of frame the information we're getting. And then the final video assessment, I would say 45 minutes. So in total, we're probably looking at an hour and a half, a little bit more time consuming than it used to be in real life.
Okay. Thanks very much, Phil. I think there's a comment here. Would it be possible to get a copy of the letter Phil talked about? So that's something we could probably look to sharing out. Overall, thank you very much. Thank you to all our speakers. I'm very aware of time. We're at 2 o'clock and I'm grateful to everybody who's still on the phone, frankly. Just to do a summary, I think there is a sense that this is something that's going to stay for the immediate future. Technology is certainly being used everywhere, but there are concerns about how do you map the quality of what you did before and after, but perhaps also recognition that we need to provide a service because there are people out there who are dependent on the diagnosis. And whatever you think about the goods and bads of that, that is still a valid need. E-prescribing was something that really popped out at me. It looks like all the services are looking at variations of that. And being a GP myself, I think that would be a very useful tool, and most of my colleagues would appreciate that. I was also struck by the fact of a subtype diagnosis being offered even without a scan. Now, that's something that historically has been a challenging issue. So it's great if in these challenging times we've been able to solve some problems which have foxed us in the past. I don't think there are any other questions popping out. So I'm going to take this opportunity for thanking everybody, and I hopefully look forward to seeing you when we run one of these things in the future again. Thank you very much for joining us. Bye.